Okay, so then to begin, the first part of the talk is going to be focusing on the MCQs. I don't want to spend too much time on this because a while ago this was like a really new way of going about things, changing over to MCQs and how we marked them and how the standard setting was done. But I think it's becoming pretty familiar to most people. So I'm going to go through it quite quickly, but please, if necessary, just stop me along the way to get clarity. So the MCQs is obviously the written components of the exam. It consists of 2 3-hour papers, each of them containing 75 A-type questions. So that means there's a single right answer. The other 3 distractors are incorrect. They're largely scenario-based. They would try to make them as clinically relevant as possible. Sometimes that's easy to do, other times it's a little more difficult, but in principle, we're looking for people to apply the knowledge they have rather than simply asking them to regurgitate facts that they've acquired over time. It really is about trying to evaluate a kind of a higher level of understanding of the information that you have, rather than just answering that the first cranial nerve is what and giving a name. It will include pictures and photographs. The exam is blueprinted, or the MCQs are blueprinted, and I'll show you the blueprint. It is available on the website as far as I'm aware, just so that there's a reasonable representation of all the domains of pediatrics that we think people should know, and therefore that's why we want to examine them. There also is some thought given to focusing on things that can't otherwise be tested in another part of the exam. And this is a theme you'll see me bringing up throughout the talk, where when you talk about each of the various stations, much of the discussion, much of what goes into deciding what a particular station includes is, well, is this an important thing to test, and could it be tested better in another part of the exam? And if the answer to those is no, then that's the right place to test it. So things like emergencies, life-threatening conditions, things with pathognomonic features, things that show up well on slides and photos and lab results. Those are the sort of things that will be focused on. The next slide is not really mine, and I'll tell you why I'm saying that. It's some MCQ tips that were put together. This whole presentation is a few different people who worked on it over quite a long time. Each person kind of adding a bit and taking a bit out. So the reason I'm saying it's not really my slide is that very first point there, where it says study, study, study. And I mean, yes, I'm not saying you can't, you'll pass without studying, and I'm not saying you don't need to study at all. I'm not suggesting that for a second, but the second point is mine, and that's what I do strongly stand by this, is that the people who kind of do well in the exam and pass the exam, and that's really all you're interested in is passing the exam, do so because they apply the knowledge that they've acquired at medical school, internship, comm service, medical officer time, at the bedside during registrar time, listening to the discussions that take place within the department, both formal presentations and less formal discussions, because that's the sort of knowledge that you need, and that's the sort of knowledge that your examiners have and think people need. So the vast majority of the information you need to pass the exam is the stuff you've picked up along the way that you already know and now need to apply. Yes, often because it improves your level of confidence going into an exam, preparing for the exam and studying for the exam is something we certainly would encourage. But when you look back, and people don't believe me before the exam, but when I talk to them about it afterwards, when you look back and think about, okay, what information did I really use to pass the exam? It's a very small amount of it is actually made up of what you studied just prior to the exam, or in the 3-4 months leading up to the exam. But doing that studying and knowing that your knowledge is good and up to date and sound certainly gives you a level of confidence that is useful to have going into the exam. Not overconfidence, not arrogance, but a reasonable level of confidence that you know what you need to know, and you know what's required to pass the exam. Just a couple more things on the MCQs. Budget your time. It's not a test of how fast you can complete MCQs. Obviously, some people do it quicker than others, but getting through 75 questions in 3 hours is only 25 questions an hour, so you've got more than 2 minutes per question. Some of them you'll be able to do very quickly, others will take more time. So you do need to keep an eye on the time and make sure that you're not falling behind. But most people finish quite well within the time available, and that's how it should be. It really isn't about seeing how quickly people can answer questions. There's information that you need to fill in your name and your student number and various things in various places. So just please take careful note of those instructions and do those before you start. Read everything very, very carefully. We try to make the kind of lead-ins to the questions as relevant as possible. So if something has been included there, it's because it has some relevance to helping you figure out what's going on. There will seldom be things there that are just included without sort of any sort of rational basis, without giving you some direction as to what the condition is or what the right answer is. They're not perfect, and no one's ever going to pretend that they are, and I'll talk to you a bit about how we go about after the exam's been written, correcting for that. But they have been through a fairly rigorous process. Some of them will have been used before, and that's I mean, I don't think that's a secret, is that if there are now a good few hundred MCQs that have been used, and a proportion of them will be recycled through exams. That's for a number of reasons. Firstly, because we know they work, we know that they're good questions, we know they discriminate well, we know that they're not neither too easy nor too difficult, and because they're testing important concepts. And also we can use those so-called tracker questions to see how different kind of cohorts of people writing the exam compared to those that went before them and others that will follow in the future, to see whether the performance on these questions is similar across time, because in essence they should be. It's not that it doesn't compromise integrity of the exam, because if there are 1,000 questions there, there's no way people will be able to realistically come out of the exam and regurgitate those to other people and use that as a way to kind of cheat the system. And there are lots and lots of new questions that are put in for every exam also. The cover test, this really refers to reading the lead-in and covering the answers and trying to answer the question without seeing the options that have been given to you. Because it's what we do when we're setting the papers, it's what we tell examiners to do when they're submitting questions, because it's, again, not always possible, but for many of these A-type questions, a good A-type MCQ doesn't necessarily require someone to read the options. The answer is often able to be worked out and answered and provided just from the information that's provided in the vignette. And if the answer you think it is there one of the 4 answers, it's almost certainly going to be the right answer. Don't ignore the others, because there may be, I mean, others are put there as distractors, and it's quite plausible that something you might have missed in the vignette led you to one of the distractors, and that's why you gave that as the answer when you applied the cover test. But then when you see the alternative, you'll think, okay, fine, I see what's happening here. I forgot about that bit of information, and now when I reconsider, that's actually the more correct answer. But more often than not, your first instinct is going to be the right one. A couple more tips on MCQs. Don't spend long periods of time on difficult questions. Just make a note somewhere that you're going to come back to it. Apply the process of elimination. What that means is going into a question, if you know nothing about what the answer is and you were to guess, you've got a 1 in 4 chance of getting it right. Whereas if you're able to go through the information that's provided, and you can clearly say, okay, A is definitely wrong, so now you're down to B, C, or D, and you've improved your chances, if you really don't know which of those is correct, from 1 in 4 to 1 in 3. And if you can do that even further, then you've got it down to a 50-50. And yeah, as you move through, eventually, if you're able to obviously eliminate 3 of the 4, then you've got the correct answer, even if you don't actually know that was the right answer for that particular question. be very, very cautious about negative lead-ins. What I'm saying is things like which of the following is the least likely diagnosis, or which of the following 4 medications would you avoid? Those sort of kind of negative lead-ins. Not because, I mean, we do try and limit the number of those, so you'll see that there are very few questions like that. Out of the 150, probably less than 10% of them will have negative lead-ins like that. But there just are some concepts, that are some questions that it's really difficult to have it without a negative lead-in. And the reason I'm saying be cautious of it is because just logically when you're going through it, when you're thinking about it, which is from kind of a positively phrased lead-in compared to a negatively phrased lead-in, you need to be a little bit careful that you don't get confused. So when there are negative lead-ins, please just be a little more careful about how you're answering that question, because it can get a little more confusing. Should you guess? So I'm opening that up to the group here. What would you do? Do you think it's worthwhile guessing? Anyone want to tell me their approach? Yeah, Jacques, go ahead. Oh.
Yes, if I don't know, I will end up guessing. I cannot just leave it empty.
Okay, but I'm saying, is it to your advantage to do that? Is it better for you to leave it blank, or better for you to just put in an answer that you don't actually know the answer to?
It's better for me to put just the answer.
Okay, anyone with a different view?
I agree, because there's no negative marking, so you can either gain, or if you don't guess, then you are definitely not going to get a mark for it. But if you guess by accident the right answer, then at least you have gained something.
Yeah, so I mean that's correct. So both of you are right. Essentially, there is no negative marking. I'll go through the standard setting of marking now. But so if you leave a question blank, you're going to get nothing for that question. If you make an informed guess, and particularly if you're able to eliminate one or two of the options, you can only gain from it. Check your work. We recommend to people that they mark their answers on the question paper too, because that does get handed in, and that's just a backup. If anything were to happen to your computer mark sheet, it is then possible to go back and look at the answers that you submitted. But what a lot of people do, which is a fairly good idea, is to answer the paper on the question paper, and then at the end go back and fill in the answers on the answer sheet. As I said, that's not a bad idea, but if you kind of miss one out, and so therefore all your answers are kind of one question out of sync with what they should be, you're going to essentially lose all those marks you should have got. So just check that you've filled in the mark sheet correctly, that you're happy with all your answers. As I say, there's usually more than enough time to do so. But you want to get credit for your knowledge and not kind of lose marks for sloppy mistakes like that. Okay, so this just shows you the blueprint. I'm not going to go into it in a large amount of detail, but you can see that it's broken up that about okay, so yeah, so on the left-hand column there you can see the let me just see what I've done here. Okay, this is an actual paper and how it's been blueprinted. So you'll see that category A questions are intended to make up around about half of the paper, and those consist of things that are make up the bulk of clinical pediatrics. The other half is firstly the so-called SCAP questions, social community ambulatory pediatrics, that make up about a quarter of the paper, and you can see the various things listed there. And then category B questions, which make up the kind of less day-to-day aspects of clinical pediatrics. They're still important, but they make up roughly about a quarter of the paper. So what happens then is the paper is put together, it goes through a whole moderation process, the candidates write the paper, and then afterwards the performance of candidates on each question gets evaluated. And you end up with something that looks like this. This is just an example. It doesn't represent a real exam. If you were to count them, you'd see there are 150 black dots on the graph at the moment. Each of them representing the performance on one particular question. And what's being shown here is the discriminatory index on the y-axis and the easiness percentage on the x-axis. And essentially what that refers to is the easiness percentage is what proportion of the people writing the paper got that answer correct. And questions that with the easiness index is less than 25%, what that essentially implies is that someone who didn't even read the question, who had no knowledge about the subject, simply guessed at random, would have done better than the cohort of people that actually wrote the exam. So you can see that that's a particularly difficult question. And so these questions here are those that you would have done better by just guessing than by actually reading the question. And you can understand why that's potentially problematic. And then these questions up here where they're too easy, where almost everyone gets them right. So that's what the easiness percentage refers to. The discrimination index is a little bit more difficult to understand, but what it essentially speaks to is how well the performance on that particular question was able to discriminate with respect to how well people did throughout the whole exam. So how well that question corresponded to or correlated with the actual final mark on the paper. So essentially saying, so a question with a good discriminatory index was effective at differentiating between those people that ended up doing better on the exam than those people that did less well on the exam. Ideally, you want a discriminatory index that's as high as possible. You're not going to get, I mean, with 150 things, you're not going to get very, very high DRs, but you certainly want a positive DR, a negative DR with those of these down here. What that essentially means is that on that question, the people who ended up getting a lower overall mark did better than the people who ended up getting a higher overall mark. And so that question did not discriminate between the better performers and maybe the poorer performers. Now that doesn't necessarily mean that it's a bad question, but it's a marker that there might be something wrong with the question, as is the questions that have very low, very high easiness percentages. So what happens after this is that the MCQs are looked at and potentially some are excluded. And the ones that are particularly looked at for possibly being excluded are those with negative DRs and those with very low easiness indices. Not that they automatically get excluded, but they get looked at, they get considered by the examining panel, by the conveners, by the moderators, and they get to look at the questions and say, okay, the reason this one didn't perform particularly well is it's poorly phrased, and so candidates got confused, and therefore that's the answer. That's the way they answered the way they did, and so it's not fair to keep it in, and that gets removed. And so that kind of discussion takes place around all of those potential questions for exclusion. And so what happens is you end up with this being your initial graph and potentially some questions being excluded. So you can see here, this isn't necessarily what absolutely happens, but what we've seen here is all of those with very low easiness percentage, so very difficult questions were excluded, and all of those with negative DRs were excluded. And so you end up with 120 or 130 of the 150 questions being included. Then the next thing that happens is a sort of standard setting process. Now, I don't want to spend too much time on this, but just what this refers to is how do you decide what the pass mark is for that particular paper. So the old days of having an arbitrary pass mark where you said 50% of the pass mark or 60% of the pass mark or some other percentage of the pass mark is no longer considered acceptable in most sort of settings, because it doesn't take into account the fact that some papers are easier than others and some papers are more difficult. It doesn't take into account that some cohorts will be stronger compared to other cohorts, and so there's a whole branch of medical, not just medical education, but education around standard setting and how you kind of find the appropriate pass mark for that particular paper for that group of candidates. And this matters because this determines people whether they pass or fail, and importantly, if we pass people who don't deserve to pass, that has implications for themselves and for their patients in the future, and conversely, if we fail people who should be passing, that has real implications for the people writing exam. So it's appropriate to try and find the right pass mark. There are lots of ways of doing that. That's just what we kind of touched on already. The Angoff method is one of them. I'm not going to spend too much time on it because it's one we don't actually use. But what is widely, just so you understand the concept, because the principle does kind of carry through in other areas, is a group of expert examiners are asked to consider a borderline student. What they're saying is, think about a person who has just enough knowledge to pass the exam, no more and no less than that, a hypothetical person like that. And then look at each question and say, what proportion of a group of those borderline students would you think would get that answer right? So for a very difficult question, they may say, sure, only 30% are going to get it right, only marginally more than those that actually, if they're actually guessing. And in an easier question, it's going to be sure everyone's going to get this right. There's going to be 80 or 90. And then all of those judges put all of their assessments together, and they use that to come up with a pass mark. So if the paper is particularly easy, the pass mark will go up. So you need to know, you need to have performed better in order to pass the question, pass the paper. Whereas if it's a particularly difficult paper, you'll need to have performed less well or got fewer questions right. And you can see so that corrects for the difficulty of the paper, and to some extent considers, but it all hinges on, are these people actually experts, and do they have a clear idea what a borderline student is? And those are concepts that are kind of not necessarily always easy to judge. The reason it's not used is you need lots and lots of people to do it. You need at least 10 people to be going through this process to come up with a reasonable pass mark. And that's just not considered feasible for our exams. We just don't have that many people with that degree of insight. So the cone method is what's used. Many of you will be familiar with it. It's the same system that's in use now more and more in the undergraduate setting. It's also being used in the Part 1 exam. It's also at some point in the future going to be used in the DCH exam. And how it works is that the scores, so after the paper's been written, after the poorly performing questions have been removed, people's scores are ranked kind of from the people who performed best down to the people who performed lowest. And here's kind of someone in the middle. What then happens is a measure of the kind of top performing people is taken. Now, the reason for, and it's not the very, very top person, because some cohorts will have really kind of people who outperform other cohorts with respect to the top people. So you don't want the absolute top person, because that's not always fair. But what has been shown is that the kind of 90th to the 95th percentile of people are fairly consistent. So the mark, the 95th percentile, 90th percentile mark, is fairly consistent across cohorts. So you're always going to have stronger people in your group. And you start based on that, and you say, well, what proportion of the knowledge that the 90th or 95th percentile person has does the borderline person need to have in order to pass their exam? And so people use different ways of doing this. So some have said the 70% of that, some have used 60% of that, some have used 65% of that. So you'll hear people talking about Cohen 60s and Cohen 65s and Cohen 70s. So what that's talking to is the proportion of that 90th or 95th percentile mark that potentially corresponds to a pass mark. But that's not the end of the process. And I put this under details and discussion. Those discussions have pretty much been finalized within the college, and it's now essentially the same throughout all the colleges that are using MCQs. There was some debate around should we be using the 90th or 95th percentile, and currently it's the 90th percentile, so that's in the favor of candidates. So that means that the kind of you're looking at, your calculation starts by looking at the performance of the 90th percentile rather than 95th percentile. So it means that the pass mark actually is lower. So you need to get a lower mark in order to pass the paper than you would have if you used the 95th. To use 65 or 70, so currently the discussion has gone on, and it's the decision at the moment is to use the 65th. So that's again in favor of candidates. to correct for guessing, and this is what we've kind of spoken about before, is that if you give a paper with 4 responses to each question to someone or a group of people who have no knowledge whatsoever of the content, what mark would they get? And the answer is they should get somewhere around 25%. So the concept is, well, within the cohort of people writing the paper, everyone's going to guess to some extent, but the people who are stronger will have to guess less than the people who are not, whose knowledge is not quite so strong. And so therefore, when you look at the final marks, the overall proportion of the mark that actually isn't part of that person's knowledge, that's actually as a result of their guessing, will be greater for the people performing more poorly on the paper compared to those performing better. And should you be correcting for this? And it's a mathematical correction, and the decision right now is it's been removed. So correction for guessing has been taken out. Again, that's in favor of candidates. So by taking correction for guessing out, the pass mark goes down, so the proportion passed in the paper goes up. So all of these things are favoring candidates. The last thing is around adding a standard error of measurement to the pass mark. And this is a statistical concept which really looks at, okay, this is a high-stake exam. It's really important we don't let incompetent people, I'm using that word on purpose. I mean, not saying that anyone's necessarily incompetent, but the kind of logic behind this is that by passing someone who doesn't deserve to pass, we're potentially exposing their patients in the future to someone without the relevant knowledge and skills. And we want to avoid that. And if it means that 1 or 2 people who actually deserve to pass don't pass, well, that's an appropriate thing for an exam to do. And so what that does is it adds a standard error of measurement to the pass mark. Usually it's 1 or 2%. So it sounds like a big deal, but it actually makes a very, very small change to the overall pass mark. So all of these things come together when we're doing the Cohen 65, and you come up with a pass mark, and most of the time the pass mark is somewhere in the region of kind of, I'm trying to remember exactly, it's ranging like 45 and 60. But what we have seen is by putting all of these things in, it's substantially increased the proportion of people who progress through the MCQs and onto the clinicals. Okay, so moving on to the actual clinical component. So the old Part 2 exam was really based on 3 long questions with 2 examiners, 3 long cases, 2 examiners per case with and only those 3 long cases and nothing else. So what we've moved to over the last few years is a process that includes multiple cases, a whole lot of different skills being assessed, so that improves validity and reliability. They're more standardized and objective assessments, and I'll show you the anchor statements that allow for that. And there's direct observation of the candidate's ability. The old way, you kind of were given time with the child and their parent. There was no one else in the room there with you, and then you had time with the examiners. And so now that's been taken away, so candidates actually have someone watching them elicit history, communicate, perform a developmental assessment. And also what that allows for is more detailed feedback, so candidates who aren't successful at least have some idea of where they can improve on. So this is what a rotation will kind of look like. Again, for COVID times, you don't need to worry too much about this because it's not like this at all. But what it essentially shows is that everyone will have 2 long cases, 2 short cases, and 1 each of development, structured oral, communication. What it also means is that within a rotation, everyone does the same short cases, history taking, oral, developmental assessment, communication. But because of how the timing works, of the 2 long cases, each candidate sees, so there are actually 4 long cases in the rotation, but each candidate only has to do 2 of those long cases. So you'll have you'll share your long cases roughly with half the people in your rotation, and the other half of the people will do the other 2 long cases. So 8 of the stations are the same, and 2 of them are, 6 of the stations are the same, and 2 of them will be different. And the same with respect to examiners. There's 1 examiner at each station, and so you will encounter 8 of the 10 examiners allocated to a particular rotation. this is what it will kind of look like. Don't worry too much about the actual allocation, but you can kind of follow a person through. So you'll see candidate 1 goes like that. And candidate 2, the same sort of thing. So what it essentially means is everyone rotates through all the stations, but not necessarily in the same order, and you all have different starting points. And there will be times when, depending on the numbers, there may be rest stations built into it. So if we need to get more candidates through, and it's not a kind of a perfect number divisible by 10, then we'll have to have rest stations built into it. So you may have 1 or 2 rests along the way. Just don't worry about this. It's just really how the examiners work, and you can see that the examiners also get exposed to a variety of different stations throughout their examining time. That we've been through already. So the key features, I think we've touched on most of this already. So single examiner each station, you encounter 8 of the 10 of them. All of them will have written instructions outside. So how the timing works is a bell will go, and you then have 5 minutes before the next bell. In those 5 minutes, you will read the written instructions that are given to you outside the station. You'll have some you have pen and paper, and you'll be able to prepare for the station. The bell goes, and then you go into the station with the examiner and role player, patient, whatever it is, depending on that particular station, and you have 15 minutes with them. At the end of those 15 minutes, another bell goes and you leave. The long cases are the only exception to that, and that's where you have kind of 2 of those 20-minute periods running concurrently. So you still have your 5 minutes outside. You then have 35 minutes inside with the examiner and patient, etc. And then the bell goes, and you have 5 minutes to get to your next station and prepare for going to that next station. I'm not going to spend all that much time on each of the various stations. That's what we're going to be doing each Wednesday morning, as you kind of get a chance to practice those and watch other people practicing them, and we have more detailed discussion over each of those stations. But you can see there's a set time period for the performing the skill and for the discussion. Everything's observed. The examiner has guidelines or anchor statements, and the mark sheet is structured. And it's not a checklist. Some of you might have been involved in undergraduate exams where you have a whole long list of things that the candidate's supposed to do, and as they do them, you tick, 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 and at the end of the time you add up all your ticks, and that gives you the number of marks. That's not how postgraduate exams work. It's an overall impression of how you've done, but the anchor statements give them some idea of where each person should fall, or where a person's performance would allow them to fall. Okay, so now I'm just going to go through each of the stations one at a time. Long cases, and these are going to be exactly the same in COVID, but in how they're kind of run, but they will be like they were last year, done decentralized. So the WITS candidates will have their long cases done in person, so with real patients, with real examiners who present in person, and it'll be at one of the 3 academic hospitals. It's often going to be the one where you're currently allocated, so there's less movement of people around, but obviously depending how numbers allow for that, that may change to some extent. But it'll be separate from the other stations in the exam, which will be held online. The long cases will take place prior to that, probably a few weeks prior to that, and they'll be in person. And the idea behind this is it evaluates people's ability to do a general and systems examination. It's often 2 systems, or it can be one system where there's a fair amount of pathology. At the end of it, you want to be coming up with a differential diagnosis, and then going on to further discussion around relevant investigations, how you use those investigations to narrow down your differential diagnosis, and there will almost always be time to discuss management. As I already said, you get 5 minutes before to read the information, to take note of that, and really the idea exactly the same as in the MCQs is that all the information that there is relevant. Then you have roughly 20 minutes hands-on time with the patient. Typically you'll go in, you'll greet the various people, you'll not repeat the whole history, but evaluate the information you're given and interpret and say, okay, based on that, this is what I'm currently thinking, and this is what I'd like to do. And the examiner will say, right, fine, go ahead and do that. Or if that's not the appropriate kind of evaluation that you should have done, they'll kind of probe a bit further and try and get you on to where you need to be. Then you'll be able to start examining. It'll usually be a general examination in either one, sometimes two systems. You talk about your findings, both positive and negative, as you move through the systems. Some information may be available to you on request. So, for example, if most of the time for long cases, anthropometry is something you might have asked for before you actually touch the patient, but if not, you can ask for it. Often, it will usually be given to you. It may already have been given to you outside, so it may be something you could have evaluated as soon as, or commented on as soon as you came in. But there's obviously anthropometry that needs to be assessed. You may be able to ask for blood pressure. You may be able to ask for various other vital signs. And depending on how the examiner wants that station to run, you may get it, or you may be asked, okay, well, first comment on the pulses, and then I'll tell you what the blood pressure is. So we want to see, okay, fine, are you able to pick up a bounding pulse, and therefore, when you get the blood pressure, you're expecting a widened pulse pressure, as one fairly obvious example. By and large, examiners will not interrupt candidates at all unless you're kind of going completely down the wrong track, in which case they'll try once or twice to bring you back to where you need to be. And if that works, that's fine. If it doesn't work, they've been told not to kind of keep probing and keep redirecting. And if you're treating a patient roughly, they may intervene. Then with roughly 5 minutes of that, 20 minutes to go, and that'll coincide with one of the bells that's going for all the other stations. The examiner will say to you, okay, you've got a few minutes left, start bringing your thoughts together, and whatever else you have left to do, you can then do. And then they'll ask you to take a few seconds, put your thoughts together, and give them your assessment, differential diagnosis. And then your examiner will kind of go through. They may take you back if there are physical signs that they want you to look at again, not necessarily because you've got it wrong, but they may just want to check your technique again, or they may want to make sure that you've interpreted it properly. Often it is because something's been misinterpreted, either something was missed or something was found that actually wasn't there, but it's not always that. So don't think just because you've been taken back to a sign that you necessarily got it wrong, but usually that is what it means. And then there'll be time for discussion of investigation and management. The short cases, and this is one that's changed potentially quite a lot with COVID. So what I'm going to show you now, what I'm going to talk about now is how it works prior to COVID times, and then we'll talk a little bit about how it's changed. So here, the timing you're aware of, this is very, very much a focused general and systems examination. It will almost never extend beyond one system, and often won't even be a full system. So for example, it might just be cranial nerves, or it might just be a motor examination, or it might just be a cardiac examination and not include respiratory or something like that. So it very much is around a particular system. The history should give you sufficient direction to be able to choose that system. And the structure is largely the same as it was for the long case. You interpret information you're given, indicate what you want to examine. The examiner will give you specific directions on what they want you to do. They'll watch what you're doing. You present your findings as you pick them up. Again, you can ask for additional information if you need it. You often will get it, but depending on how the examiner wants the station to run, not necessarily. And they won't interrupt you unless you're going off track or mistreating your patient. With 2 minutes or the 10 minutes to go, they'll let you know that you've only got a couple of minutes left and you can start finishing off. At the end of that 10 minutes, they'll give you some time to put your thoughts together and to give your kind of assessment. Again, they may take you back to the patient if they want to. And then the discussion here will largely focus around, well, how have you interpreted the clinical signs? How have you come to your differential diagnosis? It's not about investigation and management in that discussion. If things right towards the end, last 30 seconds or last minute, the examiner will say, okay, fine, I've understood how you got to that differential diagnosis. How would you use investigations to narrow it down any further? And you might also, okay, I'm going to do this test and this result will mean that and whatever. But you're not going to be given results to interpret. You're not going to be given test x-rays. You're not going to have any discussion on management in the short cases. The sort of things that we've learned over time around the long and the short cases is people don't always note information that's been given to them. I'm trying to see what else is here. Yeah, this is all pretty much old. Most people are kind of over these sort of mistakes. But the big thing still is that information is given outside and inside the station, and candidates don't necessarily always take note of that information. The developmental assessment can either be a patient-based one or a video one. I've changed this slide, as you can see now, just crossing everything out because we've never used a patient in these stations. And the reasons behind that are many, but certainly around COVID stuff, there's no way you're going to be given a patient for a developmental assessment, so you'll be doing a video. Again, it's going to be same sort of basic structure. You've got 5 minutes to prepare outside with relevant information. You'll walk in, you'll evaluate the information you were given and indicate what your thoughts are at that stage. Often the examiner will then ask you a few questions around what the information you've been given. They'll ask you what equipment you might require, either from a picture or from a box or something like that, what equipment you might require to do the developmental assessment. And then you'll have a chance to watch the videos. They're definitely less than 10 minutes. They're usually about 5 minutes. You only get to watch the video once, so take careful note of what's happening. Try not to make excessive notes, because while you're writing, you're missing things that are taking place in the video. And then the final 5 minutes will be discussion time with the examiner based on what you've seen on the video. Often it'll be assessing developmental age, which domains the patient demonstrated fallout in, and then some further discussion around management and further referral. The focus really is on developmental screening, but obviously, for example, if the child is clearly syndromic, they'll expect you to comment on that and include that as part of your discussion. But that's not the main focus. The main focus really is on the developmental component. Language there, it will all be in English. Again, it's a complicated discussion, but that's the consensus that's been reached. And then there are no form boards. The history taking and management planning station. This obviously tests people's ability to take a focus in relevant history. It may be a child who does not yet have a diagnosis or may have a diagnosis, and the history is around evaluating control, side effects of medication, so aspects related to that particular diagnosis. Structure is fairly similar, 5 minutes before to read the instructions, plan what you're going to do. 15 minutes inside of those 10 minutes are actual history taking with the role player. With about 2 minutes left to go, the examiner will tell you you've got about 2 minutes left to go, and you'll kind of round off. And then you've got 5 minutes with the examiner. It's not about how fast you can take a history. It really is about how able you are to elicit relevant information, to interpret that information, to show that you've got a structured approach to history taking. And often you will, as part of the questioning, say, okay, you didn't have enough time to do everything. What else would you have liked to ask if you'd had more time available? And that'll be part of the discussion. The role player is given fairly detailed information, but you're not expected to go through every single thing that they've been given, and they are, and there's examiners and moderators to confirm that they're consistent with each candidate. And it really is about history taking. It's not about counseling. So it's much more about asking questions and listening to answers, taking in the information, and asking the next appropriate question. Communication station evaluates people's ability to communicate information. Structure is exactly the same as it was for the previous station. 5 minutes before, 15 minutes inside. Of those 50 minutes, 10 minutes communication time. With 2 minutes to go of the 10 minutes, the examiner will kind of let you know that you've got 2 minutes left and to start concluding. And this is very much about communication. Again, the role players got fairly detailed information, specifically including questions that they're going to ask you following the information you give them. Again, the intention is for them to be consistent with each candidate. And it's not about how can you communicate everything about the condition in the time available. It's not about that at all. It's simply about, are you able to effectively communicate? Are you able to evaluate that the person you're speaking to has understood what you want them to understand? Are you able to deal with the questions? Are you able to, if you haven't finished all the information, indicate what you haven't covered, and that you'll set up another time or do that and that sort of thing. It's not a lecture. It is a dialogue, even though you're going to be doing most of the speaking. These are just some examples of what's been given. I'm not going to go through all of those, but importantly, conceptually, these are going to be situations where a consultant is likely to be the person doing the history taking or the communication. So what I'm getting at there, compared to the DCH exam, where the person, the stations are kind of compiled with a medical officer in mind, these are put together with where the medical officer has reached the limit of what they're able to do, and they now need to involve their consultant, the specialist, and that's the sort of level it's at. So even though it may be similar topics, it's going to be at a higher level with slightly more complicated cases, for obvious reasons. The structured oral, and this is one, again, which hasn't changed too much with COVID stuff. This is really aimed at evaluating how people deal with the scenario, and how they cope as the scenario evolves. So they get a bit of information, they indicate what this means and what they would want to do next, either, for example, in an emergency setting or in whatever the kind of setting is, what they would want to do next. And okay, so fine, the next thing I want to do is give intramuscular adrenaline. And then the examiner will tell you, okay, this you do that, and this is what happens. And you can be asked, okay, what will you do next? And you kind of go through that. And you can see that this evaluates something that can't be better evaluated anywhere else in the exam. And it really does try to see how people deal with new information. It's often a case that could not be included as one of the clinical cases, so emergencies fit in well here, neonates fit in well here, young infants fit in well here, pathology that doesn't have good clinical signs, for example, like renal disease would fit in well here, and that's for the first 7.5 minutes or so. At around about halfway through the station, the examiner will shift, and you'll know they're going to do it, and you're expecting it, and some of them are better than others at doing it, but it will happen with all of them, is that to the second half of the station, which will deal with ethics or legal or advocacy or some sort of aspect that is related to the same case, but not specifically related to the kind of clinical aspects. Okay, so outside of COVID stuff, the oral history and communication stations are all recorded. With COVID, essentially all of them are recorded. You, as a candidate, may opt out of recording for those stations, but we strongly suggest you don't do that. The reason they're recorded is so that if you have a concern with how you were treated by an examiner, if they were unfair, either they treated you unfairly or the mark they gave you was unfair, that potentially you can appeal that, and then the college has the ability to go back and look at that station, listen to the recording, and see is there merit to what you're saying or not. If you decline to be recorded, what you're essentially saying is you have no recourse if something like that were to happen. And because it's being recorded, there's some specific instructions that are given to examiners to make sure they stick to the timing, that they don't prompt unnecessarily, they don't interrupt unnecessarily, that they mustn't do any teaching. It purely is about assessment, and they mustn't falsely reassure candidates. Because, I mean, as a candidate, if the examiner is saying to you, yes, good, well done, okay, fine, you think you're doing well, and then it turns out that they actually weren't happy with what you're doing, you end up failing the station. And that becomes obviously very confusing. So the examiners are told not to do that as best they can. So if what I'm really saying to you is just because they're not saying those things doesn't mean you're doing well. Okay. Sorry, doesn't mean you're doing badly. So you can be doing absolutely perfectly, but the examiners have been told not to say things like that to avoid any misunderstanding. This is an example of an anchor statement. They are on the website, so I'm not going to spend much time on them now. So, but they give the examiner some idea of what candidates have to do to clearly pass, to barely fail, or to clearly fail. This is an example of a mark sheet, and you can see that there's a whole lot of stuff that's filled in here. They mark various aspects of it. At the end of it, they just have to decide which category candidates fall into: clear fail, bare fail, pass, or clear pass. They do give a mark They are instructed to mark in multiples of 5, but the mark itself is not particularly important. What's important is this categorization here, because that's what leads to the judgment points, and the judgment points decide whether people pass or not. The overall mark becomes relevant for the very top performers who might be considered for a prize, and some universities want actual marks because they use that when they're evaluating whether people get the degree or not. For most people, you're not interested in whether you get the prize or not. You just want to pass, and whether you pass with 99% or 50% in the clinical, you pass, and that's all that really matters. So the judgment points are what you're really focusing on. This is another one. This is for the oral, same sort of thing. And now, last thing I think I really want to spend much time on is just around the marking scheme and the judgment points. And this initially takes a little bit of time to understand. But what you can see here is your mark is converted to a number of judgment points. So if you get 50%, so it's a borderline pass, you get 5 judgment points. If it's a bare fail, which is 45, you get 4. If it's a clear fail, so 40 or less, you get 3 for the long cases and 2 for all the others. And if you have a clear pass, so 55 or above, you get 6 judgment points. Overall, you have 8 stations, but the long cases count double. So altogether, the maximum you can get is 60 judgment points. So if you get clear passes on all of them, and you need to get at least 50 judgment points in order to pass the clinical component. And so what you can see is you can compensate with a bare fail by a clear pass, but you need to, if you get a clear fail in a long case, you can compensate by that with 2 clear passes, and the same again because of how the mathematics works, roughly the same with the other cases. Just to give you an example of how this works. So again, showing you the same scheme here. So you can either get 10 clear passes, and obviously you pass easily. If you get 5 clear passes, 2 borderline passes, and 3 clear fails, you overall get, so you've passed 7 out of the stations, but you've got 46 judgment points and fail overall. And the logic behind this is what we're really interested in is this candidate a competent pediatrician? We're not especially interested in are they the best possible pediatrician, but are they a competent pediatrician? And so if we don't have the judgment points, you could get 100% in one case and fail all the rest and pass the exam. And we don't think that's an appropriate system to have in place. And so the solution to that is really around the judgment points. Last couple of little things, some instructions that the observers are given. They stay out of line of sight. They don't say anything. They're expected to rotate between different stations, so that means you may see the same observer in more than one station. They're told that there's no guarantee they're going to be examining again, and the reason they're invited is primarily to help them prepare their candidates for the exams in the future. The moderators, again, they stay out of line of sight. They only observe. They're not involved in actually allocating marks. They're really there to help candidates to make sure that examiners are treating candidates appropriately. Some couple of additional things to the examiners. They're told not to ask about the university you come from. They must have their own timers. They mark in 5s. They make comprehensive notes on the back of the mark sheet so that when you're getting your feedback, there's some sort of useful information that you can get that actually makes a difference to your preparing for the next exam. What else? Anthropometry and vital signs. We'll discuss this in the actual particular stations, but sometimes they'll be given outside. Sometimes you'll ask for them and be given the actual numbers and need to plot them, but usually when you ask for anthropometry, you'll be given Z scores. Similarly with vital signs, you will need to ask for them, but you can't just kind of stand at the end of the bed and say, what's the child's blood pressure, what's the heart rate, what's the respiratory rate, what are the sats? You need to actually do something in a way, kind of earn the vital signs. So you need to have looked at the currency. The child's not pale, he's not cyanosed, but I might be missing a little bit of hypoxia. What are his sats? That sort of thing. And you need to have felt the pulse and say, this is not a bounding pulse, and before you can kind of get the blood pressure. This is a concept I've touched on already, but it's one that we emphasize to our examiners, is that the standard setting is this person a competent junior consultant? And if the answer is yes, they pass that station. And if the answer is no, they don't pass that station. And depending how far away they are from that standard, would be whether it's a bare fail or a clear fail. Okay. Well, so what's changing now with COVID? So firstly, the APLS PALS and Part 1 rules have been relaxed. So previously you had to have a valid advanced life support, or you had to have done one within the last 5 years. You don't. You will be allowed to enter the exam without those, because it's very difficult to get one of those courses done now. But what we have said to the heads of department is that they won't sign you off for registration until you've been able to do one of those. Again, and the Part 1 rules have been relaxed to some extent, so that your Part 1 is kind of valid for longer. It doesn't expire quite so soon. Candidates who are successful in the MCQs, at least last year, I'm not sure it's going to be different this year, have to agree that they're happy to be examined with the modified CCA, taking the COVID stuff into account. If they choose not to, then they can just wait for when a real, normal, old-style CCA is available, and who knows when that's going to be. Provisional dates for the written, that's pretty much set on the 4th and 5th of March. When the clinicals will be is not yet determined. At the moment, it's down for the middle of May, but that may well change. As I said, the long cases are decentralized, and the rest are going to be done virtually. So history taking, communication, structured oral development will be pretty much exactly the same as I've said here. The only difference being that you'll be at one of the college offices, you'll have a laptop and screens there, your examiner will be joining virtually, your role players will be joining virtually, but apart from that, it happens exactly the same. The short cases are slightly different, and one of them will be an emergency short case and one will be a non-communicable disease short case, and almost like the structured oral, you'll be given a little bit of information and you'll need to evaluate that information and indicate what you're going to do next, but it's going to be much more about, for example, the clinical stuff. So as if it were a short case. So if you're told, okay, this person has this history, what would you want to examine? And they say, okay, fine, based on that, I want to do a general examination and then examine the cardiovascular system, and then they're going to say, fine, on general examination, what are you going to look for? And they're going to look for color, and they'll tell you the child's pale. And look at hydration, the child's not dehydrated. And you can kind of see how you would work through almost like as if it were a real short case. And that is my last slide. So I'm happy to take questions and comments, and sorry for having gone a bit longer than I was expecting. But yeah, open for discussion. Anybody? Okay, I'm not seeing any hands. Nobody's unmuting. So then how it works from now onwards is that, okay, sorry, Nisha, yes, I did say I would get your input on how the COVID style exam went. So yeah, do you want to just go ahead and just add to what I've said?
Hi, thanks, Gary. I thought, yeah, so I just thought I'd give them feedback on my experience, and thanks for the opportunity. So I think overall, like you said, I think you mentioned most things in the presentation, that it is a very fair exam. And from my experience, the cases were all extremely fair, and they were at like a level of a general pediatrician. I think for the guys writing now, it might be a bit like, I know I felt a bit anxious about the new format, or sort of like doing it online. But just from my experience, I thought the stations were very well planned in terms of, it didn't seem unrealistic, like having a Zoom communication station or history taking. It actually seemed it seemed realistic, and the role players were really good. So like that part was quite anxious, like how do you break bad news over a Zoom session? Obviously it has its challenges, but for most part, I thought it was quite fair and felt sort of very real. And I think now we've become quite used to online platforms, so it sort of makes it more normal as such. Just in terms of the short case, I don't know if it's going to be like how ours were, but you said like it's mainly clinical. But our short case was we had to go through history, examination, and then there was investigations and management. And then from a personal perspective, I thought that there was not enough time to cover all aspects, but I do suspect that the stations might have been moderated afterwards in terms of time, because I think most candidates didn't finish. So I'm not sure if it's going to change just based on a collect one system, or will it still be the same format as ours? Yeah, so that's pretty much, so for me, the biggest change was the short cases. The rest of the stations were pretty much the same. And I thought it was actually nice to have the long cases before and then the rest of the stations via Zoom over the next, like a few weeks later or whatever it's going to be. But yeah, if anyone has any specific questions, you're welcome to also ask me. And then in terms of like technical glitches and stuff, I think the college did that part really well. There was very minimal, if any, technical glitches. I think just the timing, I know you say that you're usually given a 2-minute heads up before, like off the 10-minute station. So we didn't get the 2 minutes. And so you sort of expected to plan your station and that didn't happen. So maybe just to be aware of that, or unless they changed or are more strict about giving you the 2-minute heads up before your time ends, just to be aware that by the time the person walks in to tell you your time's up, that's the end of your 10 minutes, and then you're left with 5-minute discussion. I don't know if you want to add anything to what I've said.
Yeah, thanks, Isha. So, I mean, around those short cases, I mean, that's exactly what I mean by its clinical. So it'll start with aspects of history and then go on to clinical findings, and it should get to investigation and management, and you should actually be getting some radiology and some lab results and that sort of stuff. One of the problems, and I think you've highlighted that well, is that, and we know it wasn't a perfect exam, is that because of how it was structured, a lot of junior examiners were involved, much more so than in the past. And what normally happens is there's an examiner's briefing that takes place like the night before, like on the Sunday night when you're having a kind of a face-to-face exam, and that didn't really take place. So these little things about giving you the 2-minute warning and about how the examiner should structure their time was certainly, as a moderator, I could see that happening. I could see that it wasn't being done exactly as we would have wanted. So as part of the recommendations from the moderators is that there must be an examiner's meeting prior to the exam, and that these things will be discussed with them before the actual online versions. And so those sort of issues that you've touched on hopefully will be less of an issue. Again, we're not pretending this is perfect. We're not pretending it went as smoothly as it could have, but we certainly are aware of these issues and are hopefully trying to ensure that they have, at least to some extent, been corrected and will be better this time around. It's not going to be perfect again. I mean, we know that, and if there were a way we could do better, we'd very, very much like to try and find it. But it's the reality is it's trying to have a acceptable, efficient, feasible exam process rather than just delaying it, and which kind of plays havoc with everybody. But I think that feedback is useful. Thank you. I'm well over time, so if there are additional questions, I'm happy to take them, but otherwise I do want to end the session pretty soon. Okay, so if people have questions, they obviously can come to me anytime. And then the allocations for each Wednesday morning have been circulated. I think they're probably on the notice board. If not, I'm sure they will be soon. So each Wednesday there's a consultant and a registrar allocated, and they on this same link will do a mock station. And then I will join as many of those as I can. My purpose there is to kind of help to provide a little bit further insight, to help to give the examiners some direction too, because many of them will have examined, but some of them won't, and all of these things are new. So it's to kind of help both from the potential candidate and the potential examiner's point of view. And one other thing on reviewing submitted logbooks. Please, each time you do one of those mock exams, whether it's on a Wednesday morning or in the wards or at another hospital, please get them completed in your logbook and signed off. We see quite a lot of logbooks being submitted with very, very few mock exam cases in there, and we don't think that that's actually representing the truth. We think that many of those people have done far more mock exams than what they've included in their logbooks. So these things on the Wednesday mornings here and whichever day of the week have been done at other hospitals certainly count towards those mock cases, so please put them in there. Okay, if that's all, I'm going to end the session, and the recording will be available in the usual Reubenson academic presentation Dropbox folder sometime later today.